Hello everyone, this is Dr. Singaram. In this particular session, I'm going to discuss about pediatric recall questions which were asked in FMG section, July 2024. Talking about that overall exam, FMG exam, it was a moderately tough exam as you would expect for any other FMGs. This was also the same this time. And talking about my subject, that is pediatrics, there were good number of questions. Almost I have collected around 18 questions, 18 questions in this recall given by the students. And out of these 18 questions, I can say that at least 15 questions were from direct pediatrics and few questions were integrated with the other subjects. So pediatrics again is one of the high scoring subjects in your exams. And the other thing about pediatric question is that you usually get standard questions. There is nothing like very difficult questions and all being asked in pediatric section. Of course, out of that 18 questions, 1 or 2 questions were slightly different from the usual pattern, but still all the other questions are very much doable. So that is why we always emphasize that you have to read and revise the notes properly. And if you have done that, pediatric subject is a high scoring subject. Okay, right. So without any further delay, let me start the discussion of the questions which I have collected from the students. And before I start, please remember that these are recall given by the students who have attended the exams. But it is always possible that errors can be there. There can be some difference in the wordings of the question or in the options also. You're always welcome to comment your modifications, suggestions, or any new questions in the comment section below. And I will keep updating as and when required. And you can always refer to the first comment below for any updates, modifications, or new questions related to this particular discussion. Okay, right. So we will get started with the first question. In a child with CFTR gene abnormality, what is the likely channel defect? That is what is the question. This is one of the famous questions actually. The topic itself is famously or commonly asked in your exams. What does the CFTR gene abnormality refer to? In which condition? Yes, it is cystic fibrosis. It is cystic fibrosis. Okay. Yes. And CFTR stands for, CF is cystic fibrosis only. TR stands for transmembrane regulator. And which channel defect is it likely to be associated with? Yes, it is a chloride ion channel defect. This is something very important for your exams. And one question which can be asked further is, CFTR gene is located in which chromosome? Which chromosome number? Any idea what is the chromosome number for that? It is chromosome number 7q. That is long arm of the chromosome number 7. Okay. From a clinical point of view, there are 2 points about cystic fibrosis which you should remember. It is actually a multi-system disorder characterized by recurrent pneumonias. Recurrent pneumonias, that is an important word. And one more thing is, it is characteristically associated with malabsorption also. So, out of the different features of cystic fibrosis, these are the 2 standout features which you should remember. Okay. And one more question they can ask you is regarding the sweat abnormalities. What happens to the sweat in cystic fibrosis? It's a salty sweat. Salty sweat. Salty sweat is basically what? Increased levels of sodium, as well as increased levels of chloride. And you should remember that increased chloride level can help in the diagnosis of cystic fibrosis itself. So this is an additional point which you should remember. So these are points about cystic fibrosis, and the answer for this question is option D, which is chloride ion channel defect in CFTR. Moving on to the next question, which of the following is a likely diagnosis in a baby with rough, dry skin, umbilical hernia, and macroglasia? This is a clinical association which I have emphasized so much in the classes, even with pictures also. And I keep repeating that if you see a picture or the clinical features are given like what is given in the question, it is very, very characteristic of which condition? Cretinism, Prader-Willi syndrome, Down syndrome, or galactosemia. It's very classically cretinism. Okay, cretinism is nothing but endemic form of what? It is nothing but endemic form of hypothyroidism. Okay. So it's basically congenital hypothyroidism, but as an endemic variety is what we call cretinism. And the characteristic features are already given in the question. Rough dry skin is a common feature of hypothyroidism, but umbilical hernia and macroglosia association is always characteristic of this congenital hypothyroidism, which is given as cretinism in the options. I'll put the picture which I usually discuss in the classes. Can you see that classical picture and the classical manifestations also? This is the macroglosia association. Very, very important macroglosia association. And this is the umbilical hernia association. Umbilical hernia association. So when you get this question again, Please don't make the mistake. It's very, very characteristic of congenital hypothyroidism. Okay, moving on to the next question. It's a very easy question related to breastfeeding. Exclusive breastfeeding is till the age of 9 months, 4 months, 6 months, and 12 months. It's a very straightforward question. It is till the age of 6 months. What is the meaning of exclusive breastfeeding? It is only breast milk till the age of 6 months. But if there is a question, continuation of breastfeeds is till what time? Continuation of breastfeeds. See what happens after 6 months. You will introduce complementary feeds like the rice, fruits, vegetables and all. But breastfeeding will be continued even after 6 months also till the age of 2 years. This is also an important question to be noted. And one more important question is, when should the breastfeeding be started after birth? It's a famous question. What is that? It is as soon as possible after birth, or if that is not given, you have to choose within 1 hour after birth. Okay, right? So these are some previously asked questions about breastfeeding, which you should be knowing about. Okay, right. Moving on to question number 4, which is related to this. Which of the following conditions is likely to be associated with unconjugated hyperbilirubinemia? So increased bilirubin, but which variety? Unconjugated variety. You can see 3 genetic syndromes are given: Dubin-Johnson, Rotor, Gilbert syndrome, and one more is biliary atresia. What is the answer? It's a very straightforward one. It is Gilbert syndrome. Okay, right? No doubt about this. Gilbert syndrome is also one of the previously asked exam topics only. They have even asked case scenarios related to Gilbert syndrome also. And they have mentioned investigation reveal increased unconjugated bilirubin like that. That has been already asked. Can any of you tell me any other genetic syndrome also which is characterized by increased unconjugated hyperbilirubinemia? Just think about it and tell me the answer. Yes, Crigler-Najjar syndrome. Crigler-Najjar syndrome is also characteristically associated with unconjugated hyperbilirubinemia. If you look at the other 2 syndromes given in the question, namely the Dubin-Johnson-Rotor syndrome, they are characterized by increased conjugated bilirubin levels. Biliary atresia is also one of the obstructive condition which is again associated with increased conjugated hyperbilirubinemia. And biliary atresia was asked last time in the exam question. Like, what was the question? In a baby with jaundice, biliary atresia should be suspected when the jaundice persists beyond how many days or weeks or months after birth. What is the answer? Can you recall that? Jaundice persisting after 2 weeks is encountered in biliary atresia. This is last exam question, January 2024 FMGE exam question. So that also needs to be remembered. So that's about question number 4. The answer is Gilbert syndrome, characterized by increased unconjugated bilirubin. Moving on to question number 5. In a child with malnutrition and low weight for height, as per WHO classification, it is termed as wasting, stunting, underweight, none of the above. Here the key word is low weight for height. Okay, low weight for height. In which of the conditions do you encounter? Okay, right? It is encountered in acute malnutrition. It is encountered in acute malnutrition. Yes. And what is the term for that? Very obvious answer is wasting. Wasting is the one which is low weight for height. Then what does stunting means? Stunting means it is low height for age. H by A, I'm using in short forms. Height for age is nothing but, yes, it is WHO chart which we are talking about. It is a type of chronic malnutrition. This is also important. It's a type of chronic malnutrition. What about the third option, underweight? Underweight simply refers to low weight for age. And very, very important, underweight occurs in both acute and chronic malnutrition. It is occurring in both acute plus chronic malnutrition. It cannot differentiate. That is what I'm trying to tell you. So that is why in this particular question, when low weight for height is given, as per WHO's classification, it is always wasting. It's one of the famous questions where you should not go wrong. So that's about question number 5. Moving on to question number 6. Yet another question about malnutrition part. A child presented to pediatrician with non-lethargic, non-edematous malnutrition. Which of the following is a likely diagnosis? Kwashiorkor, marasmus, HSP, none of the above. It's again a very classical question. What are the important clues? Non-lethargic, that means it's an active child. Some of the students actually mentioned, it was also given in the question that the child had a voracious appetite, or it was mentioned like this, voracious eater. That means the appetite of the child is good. That is what they had mentioned. Some students said it was not given, so it's all up to the actual question. But anyway, non-lethargic child, non-edematous also. Which is the likely diagnosis? It's very straightforward. It is a case of marasmus. If it is actually kwashiorkor, there should be presence of edema. You all know about it. Generalized edema is one of the hallmark features of kwashiorkor. And in kwashiorkor, the child is also lethargic. And what will happen to the appetite in a child with kwashiorkor? It would be decreased. Okay, so it would be exactly opposite of marasmus, right? Kwashiorkor, marasmus are always famous exam topics. They have asked it even as image-based questions also in your previous exam. So you should be very thorough about the topic of kwashiorkor and marasmus. Moving on to our next question. A 3-day-old baby is presenting with refusal and vomiting of breastfeeds, but accepting normal glucose liquid. Okay, that is what glucose liquid child is accepting, but child is refusing and vomiting the breastfeeds. That means what? Child is not tolerating the breastfeeds. Okay, that is what this question says. Not tolerating the breastfeeds. Okay, right. Now, question is, what is the likely enzyme deficiency? They are not asked the diagnosis, but they have asked what is the enzyme deficiency in the condition child is suffering from. You look at the 4 enzymes, aldolase B, phenylalanine hydroxylase, GALPO deficiency, and glucocerebrosidase. All these are something connected to metabolic disorders characterized by enzyme deficiencies. Okay, right. So before we come to the answer, we should know what the condition is. Child is not tolerating or having an aversion to the breastfeeds means something in the breastfeeding is preventing the child to have a normal, digestion, absorption like that. So based on this clue, can you tell the answer for this? I will also go one step further. Child is not tolerating breastfeed. Anyway, you are not going to give the breastfeed to this child. And this condition is also an absolute contraindication to breastfeed. It is also an absolute contraindication to breastfeeds. Yes, now I think the answer should be clear. What is that? Yes, it is galactosemia. It is a case of galactosemia. And in galactosemia, you all know which is enzyme deficiency. It is GALPUT deficiency. What is GALPUT? GALPUT is actually an expansion for galactose, that is GA1-phosphate, that is a P. UT stands for uridyl transferase deficiency. UT stands for uridyl transferase deficiency. It is also called by another name, GALT, G-A-L-T also. You can refer to this, right? So just to have a quick idea about the galactosemia, you can see that this is the pathway involving the galactose, wherein it is first converted from galactose into galactose 1-phosphate, and then by uridyl transfer, it gets converted to glucose. And the main enzyme you can see is the GALT, or the galactose 1-phosphate uridyl transferase, the deficiency of which is what is called classical galactosemia, which is also the most common enzyme deficiency in case of galactosemia. Okay. So what is increasing in this condition? There is increased levels of galactose 1-phosphate, right? And this galactose 1-phosphate is the one which causes the problems in case of galactosemia. It can cause liver damage. It can also cause eye problems also. And I'm sure that you should be able to tell me what is the name of the eye manifestation. Yes, it is cataract only. And what is the name of that? Oil drop cataract. Oil drop cataract. Yes. So always remember the correlation between the breastfeeds and galactosemia. Basically, what does breast milk contain? Breast milk or any other type of milk is going to contain lactose, correct? Lactose. And this lactose, once it goes inside the body, will be broken into glucose plus galactose. Now, what happens in galactosemia? The conversion from the galactose to the glucose is getting impaired, correct? Is getting impaired. So that is why if the mother gives breast milk to the baby, through the breast milk, lactose will come and the galactose or the galactose 1-phosphate will start accumulating inside the body and will cause all the problems. So that is why we say that this particular condition is an absolute contraindication for breastfeeding. So for question number 7, the obvious answer is GALPUT deficiency. Moving on to question number 8, it's a question about developmental milestone. Each and every year, questions are expected from developmental milestone topic. Okay, so whether you like it or not, you should read this particular chapter in pediatrics very, very thoroughly. In last January exam 2024, we even had 2 questions from developmental milestone section. That underlines the importance of this particular chapter. Must read and must know topic for pediatric section in any competitive exams. Okay, right. Anyway, I'll discuss the question here. What is the likely developmental age in a child who can ride a tricycle, climb upstairs with alternate steps, but cannot hop? So we'll just try to put it one by one and then we'll arrive at the answer. Child is able to ride a tricycle by the age of 3 years. Okay. Child can climb upstairs with alternate steps. The key word here is upstairs. Upstairs with alternate steps is again 3 years. And cannot hop. When is the hopping attained? Hopping is attained by the age of 4 years. So this clearly tells you child should be at least 3 years, but less than 4 years. Can you understand that? Child is 3 years, but does not have a milestone of 4 years. So in the question, it was not like 3, 4 given. It was like 3.5, 4.5, 2.5 like that is given. Obvious answer for this is more than 4, sorry, more than 3, but less than 4. What is that? 3.5 years should be the answer for this particular question. Okay, right. So it's a developmental milestone related question. Moving on to question number 9. Identify the diagnosis from the karyotyping picture which is given below. It's a very standard way of asking the question and the diagnosis is right there in front of you. What is that? Look at the autosomal chromosomes. You can see the chromosome number 18 is having a 3 copies instead of 2 copies. So basically this question is about trisomy 18. Which is the answer? Very straightforward. Edwards syndrome is nothing but the trisomy 18. Correct? Edwards syndrome is trisomy 18. Patau syndrome is trisomy 13. Down syndrome is trisomy 21. Turner syndrome is deletion of one X chromosome or it is 45XO. That is what it is, right? So very straightforward answer for this question. It is Edwards syndrome from the trisomy picture which is given. Moving on to question number 11. Which of the following is the most, question number 10, sorry. Which of the following is the most likely electrolyte abnormality in a child with hypertrophic pyloric stenosis? Hypertrophic pyloric stenosis is yet another repeatedly asked topic in your exams. Hypokalemia, hyponatremia, hypomagnesemia, hypophosphatemia. See, basically in this condition, there is hypertrophy of the pyloric muscles causing obstruction in this region, correct? So what is going to happen? The contents of the stomach are going to be vomited out, namely the hydrochloric acid. So H plus, Cl minus, all of these are going to come out. Okay. And also there will be loss of potassium also, resulting in hypokalemia also. Okay, right? So if you look at this, it is hypokalemic, hypochloremic, metabolic alkalosis, correct? Metabolic alkalosis. This is what you have to remember. Hypokalemic, hypochloremic, metabolic alkalosis, right? Now, in these options, the one which is fitting into the answer is only hypokalemia. Okay, but some students said that hypochloremia was also given the option. In that case, what should I choose? Hypochloremia as the most likely abnormality or hypokalemia as the most likely abnormality? Can you tell the answer? Here, I am going to tell you the reason also. I will tell you some references also, and I'm going to tell the answer right away. It is hypochloremia more than hypokalemia. That is what I can tell you. Hypochloremia more than hypokalemia. Okay, why? Because in most of the standard references, the first abnormality that occurs is hypochloremia before hypokalemia. So that is why most likely if the question was asked and both options are given, choose hypochloremia, then hypokalemia. You can see the reference from Nelson textbook of Pediatrics itself, 22nd edition. You can see as vomiting continues in pyloric stenosis, a progressive loss of fluid, hydrogen ion and chloride ion leads to hypochloremic metabolic alkalosis. So can you see that word? Hypochloremia is the initial metabolic abnormality, then only hypokalemia occurs. So I think that part is clarified. In your future exams, depending on the options, you have to answer accordingly. That's it. Moving on to the next question. Calculate the mid-parental height for a male child whose father's height is 159 and mother's height is 145 centimeters. See, mid-parental height is abbreviated as MPH. This is usually done in children with short stature. Okay. Why? Because when the child is short, obviously parents will have a question in their mind. If this child is going to grow older, what is the height I can expect for this child? So for that purpose only, we can calculate something called mid-parental height. And mid-parental height is based on the father's and mother's height, which is nothing but father's height plus mother's height divided by 2 plus 6.5 centimeter in case of a male child. And you have to minus 6.5 centimeters in case of a girl child. Please keep that in mind. Here the question is about a male child, so I have to add plus 6.5 centimeters. So putting the values, father's height is 159 centimeters, mother's height is 145 centimeters divided by 2 plus 6.5 centimeter. So how much is that? It is 304 by 2 plus 6.5, which is 304 by 2 is 152. 152 plus 6.5 centimeter is equal to 158.5 centimeter, which is the third option for this particular question. You can see that. Okay, option number C is the answer for this question. Suppose in the same question it was mentioned as a girl child, then you have to subtract minus 6.5 centimeters from that calculated value, right? Are you able to understand this, right? So this is how you have to answer this type of question, which is a mid-parental height calculation from the parent's height. Moving on to question number 12. Again, a very standard question. A child is presenting with a weak lower limb pulse and a strong upper limb pulse. What is the likely diagnosis? You can see all are heart defects. TG is transposition of great arteries. COA is coarctation of aorta. TOF is tetralogy of Fallot, and there is tricuspid atresia. Okay, right? So, weak lower limb pulse and a strong upper limb pulse. What is the usual lower limb pulse? Femoral pulse is weak. That is what the question says. And upper limb pulse is strong. That is a radial pulse we are talking about. In which condition? Okay, it is a very straightforward question. Any answer? It is COA or coarctation of aorta. Coarctation means narrowing. Classically, in coarctation of aorta, narrowing occurs in the descending part of aorta. Okay. And you know that descending aorta is the one which is going to supply the lower limbs. Okay, right? That is why the lower limb pulses, like the femoral pulse, is weak, whereas upper limb pulse is very strong. That's all. So that explains the coarctation of aorta as the answer for this question. One more important question which some of students were given in the question was, X-ray shows some classical finding. What is that? Rib notching, very correct. But classically, which rib notching? Inferior or superior? Inferior border of the ribs will show a notching. This is something important. Inferior rib notching, yet another commonly asked MCQ question which you should be knowing about. So that was question number 12. Moving on to question number 13. This is one of the new questions, okay, right? Slightly unexpected at an FMG exam level, but still they asked this question. So for your future exams, take a note of it. And those who are preparing, please add it to your notes, okay? Calculate the daily fluid requirement in a 3-day-old baby with a birth weight of 1500 grams. So two things are important. One is the weight of the baby. Other one is a 3-day. Because this is entirely new, I cannot ask you for the answer now itself. So I will tell you the standard way in which we are going to provide the answer. This is all based on guidelines. Can you see the guidelines for daily fluid requirements in terms of ml per kg per day? It depends on the weight of the child, less than 1500 gram or more than or equal to 1500 gram. In our question, it is clearly 1500 grams. So you have to take the second row only. Okay, right. You can see on the day 1, that is first day after birth, it is 60 ml per kg per day. And subsequently, if you see the increase, it is like 15 ml per kg per day increase. Can you see that? 60 plus 15, 75. 75 plus 15, 90 ml per kg per day. 90 plus 15, 105 ml per kg per day. And day 5, 105 plus 15, which is 120 ml per kg per day. So it is 15 ml per kg per day increments. Now, in our question, day 3 is the question. So what should be the answer? It is 90 ml per kg per day. So going back to the option, it is option A, which will be the answer for this particular question. Okay, right? It's a very straightforward one taken from OP Guide textbook. So please note it for your future exams. Okay, it can be repeated. If you can recollect, I think last year or before that, one more question was asked. What is the normal fluid requirements in day 1 after birth? This was also asked as a previous year question. 60 ml per kg per day was the answer for that, right? So questions are being asked from this section. So please take a note of this. It can be modified and asked in the future exam also. Moving on to question number 14. A 5-year-old child is presenting with the complaints of standing up with the help of his hands. What does it tell you? Standing up with the help of his hands. Normally standing up is with the help of lower limbs only, but here the child is using the hands means he's having weakness of the lower limbs. He's having weakness of the lower limbs. Okay, right? He's having weakness of the lower limbs. Not only that, what is the next line of the question? On examination, he has a positive Gover's sign. I think all of you should be knowing what does Gover's sign positivity tell you. This is the picture for that. You can see that this child was asked to get up from a sitting position or lying position. He is using the hand muscles over the leg muscles. Can you see that? He's using the hand muscles over the leg muscles and he is trying to get up. So what does it tell you? There is some weakness in the lower limb muscles, but which group of muscles? Is it a proximal muscle weakness or distal muscle weakness? It is classically distal muscle weakness. Distal muscle, sorry, it is classically, I'm sorry for that, proximal muscle weakness. Okay, right? It is a proximal group of muscle weakness. Proximal muscle weakness. So Gover sign very clearly tells you the child is having proximal muscle weakness. So I will take you back to that question. Child is having proximal muscle weakness. And one more clue you can remember from this question is it's a male child. Okay. Okay. Sorry. Already the answer is displayed. It's a male child. Male child. The clue is it is a inherited condition, X-linked recessive mode of inheritance. X-linked recessive mode of inheritance. So out of the 4 options, which is the best possible answer? It is nothing but Duchenne muscular dystrophy. One of the previous questions asked in this section is, what is the gene defect in Duchenne muscular dystrophy? It is dystrophin gene defect. That was also one of your PYQs. Dystrophin gene defect. Okay, right? So this is a very standard question. Clues are X-linked recessive condition, males are affected, and Gover sign tells you proximal muscle weakness. You have to put that combination as Duchenne muscular dystrophy. Clear? Okay, so that's about this. Now, moving on to the next question, number 15. This is one of the repeatedly asked questions. A 2-year-old child is presenting with the complaints of fever and cough for 2 days duration. On examination, respiratory rate is 44 per minute with some chest retractions. However, child is able to drink and feed normally with normal SpO2. What should be the management? This question is based on IMNCI guidelines for management of respiratory tract infections. You all know that there are 3 grades according to IMNCI classification. One is no pneumonia, something like URI. Second grade is pneumonia. And the third grade is severe pneumonia. Third grade is severe pneumonia. Okay, right. Now, first of all, there is fever, cough, which tells you there is a respiratory complaint. But in addition, look at the respiratory rate of the child. Respiratory rate of the child. What is that? Respiratory rate of the child is 44. And for a 2-year-old child, the respiratory rate 44 is increased. Because after 1 year, more than 40 per minute is considered to be fast breathing. You should be knowing about this. Okay, more than 1 year per minute is more than 1 year, 40 per minute, more than that is considered as fast breathing. So this child is having fast breathing, so it cannot be pneumonia, because in no pneumonia, there is no fast breathing. Not only that, some chest retractions were also present, which can be encountered in pneumonia as well. Now we have to divide whether this is a pneumonia or a severe pneumonia. Okay, in severe pneumonia, you have to look for danger signs. Danger signs. The common danger signs are child not able to feed, not able to drink, child is lethargic, and also child is having low SpO2. But here it is clearly given in the question, child is able to drink and feed normally with a normal SpO2. So there are no danger signs. So for all practical purpose, we are dealing with pneumonia in this particular situation according to IMNCA classification. Now tell me what should be the answer. It is a first option, give oral antibiotics and warn parents about the danger signs. Send home with only paracetamol is for no pneumonia, which is not the case here. Immediate hospital referral or hospital admission and all is for severe categories of pneumonia, which is again not the case here. So for this particular question, the clear answer is going to be option A. Now moving on to the next question. Bited spots are seen in which vitamin deficiency? Bited spots are seen in which vitamin deficiency? It's a very straightforward question. Nobody is going to make a mistake for this and all. It is clear case of vitamin A deficiency. Very straightforward, easy question. Now, other 2 questions are there, which I have not collected the full stem, and it is more like an overlap question. Okay, question number 17, you can see it is written, child is having chronic diarrhea plus dermatitis association. This dermatitis is dermatitis herpetiformis, which is more often a late onset manifestation. But which condition is it associated with? Chronic diarrhea and dermatitis herpetiformis. It is celiac disease. Okay, it is celiac disease. Okay, right. What about question number 18? What is the IV fluid of choice in a child with a diarrhea and dehydration? It is Ringer lactate plus 5% dextrose is the ideal answer. Okay, because in young children, hypoglycemia can be an accompaniment. So Ringer lactate plus 5% dextrose is the ideal answer. But if that is not given, you can choose Ringer lactate. So depending on the options, you have to choose your answers. Okay, right. So that's about the questions which were asked in the pediatric section in this recently conducted FMGE exam July 2024. So as you can see, the questions are not very difficult except 1 or 2 questions which are always expected. But other than that, all the remaining 16 questions are something which are easily answerable, and you can get all of that correct in your exams if you follow the notes properly and revise it at least 2 times before your exams. So with that, I am concluding this session and I wish you all the best for your upcoming exams. Thank you.